Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations. Welcome to another episode of Life in Sirens. Today it's going to be me, Obs, and Soph, and we've got Austin back with us.
Woohoo!
Woohoo!
We said we'd have him back. We didn't know it'd be this soon.
I'm so excited.
So today we are going to be talking about RSI and DSI and really just like using them, not using them, when you use them. So for anyone that is not a paramedic or a critical care medic, RSI stands for rapid sequence intubation, and then DSI stands for delayed sequence intubation. And those are in reference to the drugs that you give and when you give them. So in RSI, you'd give, like, say you use ketamine, or even if you use like etomidate, you'd give your sedative or your dissociative first, and then you immediately give your paralytic. And then in DSI, the delayed sequence is not really like defined as a time, but you give your sedative / dissociative kind of progressively until you reach a appropriately sedated state, and then you give your paralytic. And so we're gonna kind of just talk about when you would use either one, or do we think that you should ever use RSI or only use DSI? Bum bum bum.
For the record, we're going to talk about things that we might not necessarily have at our services, but they might be at your service, or they might be at some of the services we work for. I know that some states don't have RSI, and some have like drug assisted, and there's just, I know that this varies across the board. So don't come for us if we will be talking about RSI and DSI based on our experiences, based on our protocols and things like that. So if it's a little different than you may do it in your region, that's okay.
Take a deep breath, especially for the ones who can't.
My goodness.
Or we'll put a tube in you.
Oh my gosh.
Yikes.
Oh my god.
I loved it.
Everybody needs an
Oh
version.
my goodness. All right,
Well, do we want to talk about, we just break it down all the way, talk about some of the drugs you may see,
yeah.
and then we'll move into what the process is.
Yeah, so some of the drugs that you may see for RSI or DSI is going to be ketamine, etomidate, or like a Versed fentanyl combo. A lot of services will combine Versed and fentanyl. That's kind of like if you really don't carry anything else, that's what you do, and you can use it for sedation afterwards. Etomidate has been pretty traditionally used with RSIs and DSIs. And then ketamine, which is kind of the new preferred, I would say, standard med. And we carry both ketamine and etomidate. And then your paralytics, you have succinylcholine, rocuronium, and vecuronium. And we carry rock, sucks.
Sucks.
And then
Where's William Hauser when we need him?
You know where he's going to be? He's going to be at Crash and Learn. He is the keynote.
He's the keynote.
Oh,
I'm very
he's
excited.
gonna be good.
Sorry, shameless plug.
Wonderful. So as far as our induction agents, ketamine is going to be your dissociative, and so that one, we like it because it keeps your airway reflexes intact. So when you're talking about DSI, you want to be able to pre-oxygenate your patient pretty effectively. Keeping their airway reflexes intact is a good way to do that. Etomidate is a good sedative, but it is going to affect your airway reflexes. And then Versed and fentanyl, it's really just tough to titrate those to people specifically. But those are our three, or four, I guess. And then our paralytics, you've got succinylcholine, which is a vesiculating neuromuscular blocking agent. And we don't like it because essentially the way it works is by giving it just dumps all your acetylcholine.
It's dumb to me. Like, I really get frustrated because the argument is that it doesn't last as long as rock. I am so sorry.
Like
You have
what?
committed. Once you're pushing a paralytic, you have committed. I'm
Yes.
sorry.
I
Well,
agree.
even to start the process, if I have given you your ketamine or your etomidate, I'm committed.
Yeah.
You're getting your paralytic after
Yes.
that. You know what
Yeah.
I mean? There's no situation where I'm gonna be like, oh, I gave this, but
Well, let's
we're
just
gonna
let it
hold
wear
off.
off.
No.
Right,
No.
and like the context that we're talking in emergent airways.
Right,
These are
this
people
is-
that they need an airway regardless.
And we
If-
probably know nothing about them.
Yeah, and so like regardless if you think you can get it or not, like that's not a good reason to me to use like a crappier medicine because
Yeah.
you're like
No.
it's shorter just in
I
case.
have
Yeah.
really strong feelings
Right.
about that.
And it sucks if you're catecholamine depleted. It can cause a lot of issues. It can cause catecholamine depletion. Like it's just not great.
Not too long ago, we had a crew come in from a surgery center, and they brought a patient who did not wake up after her
Mhm.
procedure, and they did not give any further sedatives, but she was just,
Yeah.
they got
She was
sucks.
just paralyzed.
Yeah.
Mhm. Yeah, it just dumped everything.
Mhm.
And
Um,
that sucks.
And it does suck.
Stop it.
Austin, what are the contraindications of succinylcholine? This is my favorite rant that Austin goes on.
Man.
I
well,
feel like one time we were literally standing outside one of the trauma bays, and he was so mad about it.
Well, and so I always hesitate on any drug because I am no pharmacist. I always hesitate to down a drug, but just based on my experience, there's so many contraindications for succinylcholine. Obviously, we deal with contraindications daily with any med we give, but I have never seen as many as I have seen with succinylcholine. And for the longest time, that was why it almost made me afraid to even use it.
It
It's
is
because I'm
kinda
like, what if I
scary.
forget one of these? You
It's
know what I mean?
rare, but it's like,
Yeah.
it's
Right.
bad.
Yeah, you got, your malignant hyperthermia, you get your K issues, and, you need to try to worry about whether they have kidney or liver function issues and blah, blah, blah. And again, going back to an emergent airway, we just don't know most of the time.
Yeah.
I think it's
So-
a bit silly to have a drug that has so many contraindications, and the patient population that you will be using this drug on is somebody who cannot answer those questions for you.
Correct.
So, like, that seems silly.
And
Yeah.
I think it makes more sense in a surgical setting. I think there may be, and
Sure.
again, I'm not a surgeon, I'm not an anesthesiologist, I don't know. I think in a surgical setting there are probably situations where succinylcholine is going to be the preferred over Vec
Absolutely.
or,
And you can control for that. You know
Correct.
their history, you can have a conversation with them, you make sure they're NPO, you do all of these things, and you want a quick on, quick off because you're only paralyzing them for the intubation phase.
right,
And they can be not paralyzed for the rest of surgery.
right,
And I think that is an important point when people talk about it. And I think a lot of studies that were done initially that were like, oh, it'll be good for emergency medicine were
Yeah.
done in those settings.
correct.
But we don't have NPO patients. We don't know their history. If we do have some family on scene, we all know how that goes,
Yeah.
But yeah, sucks is it's a rough one.
Yeah, I just don't think that it is best utilized in emergency medicine.
I agree.
Not a huge fan.
For those of you guys who are not as familiar or as passionate with your hatred towards succinylcholine, it causes a pretty big potassium shift. So that's what Austin was talking about with issues with your potassium hyperkalemia. And so patients with burn injuries over 48 hours usually, crush injuries, spinal cord injuries, prolonged extrication, prolonged ICU stays, end-stage renal disease, patients with who are on dialysis, things like that. That's a long list, and that's just the hyperkalemia patients.
Yeah.
And then, like he talked about too, patients with malignant hyperthermia. Obviously, some people know this runs in their family, but like again, we can't talk to them. It's a very scary thing. And then anybody with like demyelinating conditions, like you also don't know that about people. Like there's just like too many things. You can't use it in
Mhm.
kids. Like I'm just like, come on, why are we
Right.
even having this?
And I will say that thankfully now, a lot of services that do still carry sucks also carry rock,
Correct.
which is a step in the right direction.
Yeah, we were there for not too long ago.
Yeah.
Yeah.
Did you know fasciculations can increase intra-abdominal pressure, which can cause a higher
Mhm.
risk of aspiration?
Really.
right?
Why would I want this?
Right, which for our non-NPO patients
Yes.
is like not ideal,
Terrible.
Mm-hmm.
right? So that sucks.
Sucks.
We've talked about all of its shortcomings. Its benefits are that it wears off quickly.
I was gonna say, don't talk about her in a good way.
And that is the beginning and end of that list.
Yeah, that's it. That's pretty much the.
I
Extent of that.
understand that rock is much longer. However, if you have a prolonged encounter with this patient, you're gonna hang sedation.
For sure.
It's okay. Fentanyl hangs in fentanyl.
For sure.
So
And what sucks, its onset is within like 30 seconds. It's like a super quick on,
Yeah,
and
and-
then it wears off in about like 10 minutes.
2 to 4.
Really?
Yeah, it's quick.
I think it's on here. Hold on.
Jeez.
I think whenever we had a protocol for it, I
You
think
can't
our
even
protocol
DSI
said
somebody
5
on
minutes, but,
sucks.
Yeah.
Yeah. 4 to 6 minutes.
4 to 6 minutes. Okay. So Sucks has a pretty quick onset, and then it's off is 4 to 6 minutes, and then Rock actually has a decently similar onset if you dose it correctly and you push it correctly. But even on its longest onset time, it's like a minute.
Yeah.
And then its offset is 30 to 40 minutes, kind of depending.
Yeah.
I think the last time I looked at it, it's around 30 minutes. Roughly a half
So,
hour.
yeah. Its onset is 45 to 60 seconds, and duration is typically 30 to 45 minutes.
Yeah, not bad. And so a lot of
Which,
times
that's great for transport.
that's great. And then Vec has about the same onset as Rock, but it lasts upwards of an
I was
hour.
gonna say it's an hour
That's
plus.
serious
I believe.
business.
Yeah, serious business.
And Beck, you have to reconstitute.
Yeah, and a lot of long transport services will use Vec.
Well, and I think VEC may be an option for certain people.
It also takes 2 to
with the
3 minutes for onset.
Right.
It's
With
a
the
long
reconstitution,
Yeah.
though, I think that there's validity in that. I wish we actually could reconstitute our rock because we have to change it out so often
Yeah,
if you don't
if
have,
you don't have it refrigerated.
refrigeration or something like that. So I think there's merit to that, but I still prefer the rock. It's
Yeah,
us personally, we don't need an hour plus. Now,
Yeah,
there's
I
some
hope not.
services, Colorado and those kind of places.
yeah,
they may-
where you
they-
can use
yeah.
it. Maybe you won't necessarily use it in an RSI situation because it does have such a long onset, like that 2 to 3 minute onset. But you could use it to then like reparalyze for like
Correct.
long-term paralysis, which would be useful.
Yeah.
Not for us specifically, but for other services it could be.
We talked about this with some people who, when we were in Kentucky,
Mhm.
is they had VEC, and the purpose was because its shelf life is longer.
Yeah.
That's pretty much the
Yeah,
only.
that's pretty much
The
it.
other service I work for, we have the exact same thing. We
Yeah.
carry VEC, but it's strictly because
You don't have to refrigerate.
no
it.
refrigeration,
Yeah.
easy to reconstitute, so you don't have to replace it so
Yeah.
often. So
Yeah, which is it has value, especially in services where like one, you have budgetary constraints.
yeah,
And like there's like an access
Yeah.
issue. Like you could have a long transport or you could
Yeah.
be short. You don't
Still
know.
better than sucks.
It is still better than Sucks. Man, that 4 to 6 minutes though, people really hold on to that.
I don't understand it, and like, I even in the ER when that's what they say, and I'm just like, what? Am I just missing something here? Because why the heck? This person is already being, like, they're unresponsive, near unresponsive, or
Mhm.
headed towards unresponsiveness, which is why we were doing this.
Yep.
So why are you literally going to sit there and tell me that you're going to just let this paralytic wear off and then just say, never mind?
Yeah, we actually didn't
Round
need to,
2.
like we didn't
Yeah.
need to do that. Like no. Yes, you did.
What in the world? Like, I just don't get it. I'm
What
like,
is going
please
on?
explain that to me. Somebody told them that one time and they held on to that.
And yes, and it's just been passed around.
That was a pharmacy rep for sure.
Yeah.
They were
For
like,
sure.
and if you screw it up, it wears off in 6 minutes.
the
And they were
person
like,
who told them that
"Ooh."
was also the person that was like, you know what, you should really deprive your COPD patients of oxygen because of their hypoxic drive. And that's the
Yes.
same person.
Yes.
That was
you
the
know,
same person. Yeah. He said, "Oh, we should not be doing this anymore." So those are our 3 paralytics, and it really depends. Like, kind of talk about like where you are, what your service is, what area you're in, and what you carry. We carry rock, so for the purpose of today's conversation, we will probably mostly talk about rock. And yeah, that's kind of our outline of our meds that we're going to talk about today. So moving forward, when do you guys choose to RSI a patient, or do you choose, or do they make you choose?
They make me choose.
They make me choose.
They make me choose. I think you need to be fluid and flexible because you guys know as well as I do. every patient presentation is different. And so, I don't like necessarily having a checklist per se, but I do think there's confounding factors that all of us would look at a patient and go,
Dang.
that tips the scale,
I feel like
Yeah.
most of the time, if any of us are on the call together, we just know. Like that one we
Yeah.
had. I was like, I'm going to go back to the truck if you guys want to get them on the stretcher, and I'm going to
Yep.
pull up them drugs.
Yeah, my I think my tip of the ice, kind of tipping point, is altered mental.
Yeah.
And that sounds kind of silly to say, but when when someone's struggling to breathe and then they start just looking around like no one's home, and you're like, oh
stare.
Or
crap.
you put them on
Mhm.
BiPAP and you think it's going to fix it, and then they just get more and more, and you're just like,
Yep.
Right, they start to calm down a little bit, and you're like, okay, maybe we're improving, but then you can see in their eyes
Yeah.
that they are losing it, and you're like, oh,
massively obtunded and
dang it. Yeah, altered mental is always my that's when I start getting things out and getting prepared.
I think that's a good
We're headed
point.
that direction.
significant injuries that could affect the airway, clinical course. There's lots of reasons.
Mhm.
I think that for me, yes, you have to make me do it, but if I know that this is not getting better, then we should probably, if it's not going to get better, we need to do something about it, right? And we better do
Yeah.
it before it becomes a crash airway.
And exactly, because I think that we find ourselves a lot of times where we are I don't wanna, maybe the ER, we can just let the ER do it. It's more controlled. I think a lot of EMS providers find themselves in that mindset,
Yeah.
but it can become a crash airway still on you
Yeah.
later on. If you see that coming and you know that right now they're dumping catecholamines, they're going to get depleted, they're going to get hypotensive.
They're just getting sicker.
This is our problem. And once they get hypoxic, if they're not already, it's going to be a lot harder to get them back to a decent place to even be able to intubate them without a lot of risk.
Definitely. And speaking of that, when do you guys feel, because I think this is a harder thing for us to tackle, but I know you guys are respiratory magnets, and we think RSI a lot of the times it's in patients who have significant trauma, like head injury, facial injuries, or just super altered mental status. They have some other mechanism of illness or injury. But what about when the patient does have a respiratory in nature illness? When do we pull the trigger on RSI?
I'll be honest, for me, those are a little bit more difficult.
I think so too.
Yeah, because going back to the clinical course, sometimes, well, we all know, you start dealing with respiratory patients, you've seen those ones who you give the smallest treatment. You give an albuterol or a duoneb or something like that, and they turn around real quick. And you're like,
Yeah.
wow, didn't see that coming. Then you've also had those ones where you're like, okay, I threw the book at them. I gave them duoneb, they got Dex, they got, all this stuff, and they got BiPAP, and still nothing.
Yeah.
And you're like, okay, one of them has got to work. And so those for me
Yeah.
are a little bit harder to pull the trigger on.
Yeah. I think we have so many tools, especially at our service. We can BiPAP people. I know a lot of services only you can CPAP, and that's kind of your limit. And a lot of patients do worse on CPAP.
Mm-hmm. I've ended up
I've seen
RSIing more patients from CPAP,
Yes.
where we have declined rapidly post CPAP.
Yeah.
Since we've gotten the BiPAP, that has been the opposite.
Mm-hmm.
I will say respiratory patients, for me, they end up being my longest. They get my longest fuse.
Yeah.
Because
with
they
that.
can turn around so
Yeah.
quickly.
Mhm.
And I think that these are the patients that I kind of beat myself up on the most after we get to the hospital. And they're like, all right, we got to tube them. I'm like, damn, should I have just done that before? But most of the time my answer is no, because you want to give them the longest possible chance. Because if they're already a pulmonary patient, then the chance of them coming off a vent is not great. We don't want to send them down a course that could be
Right.
the last decision that you get to make, really. And so I think that I give them a long fuse, but sometimes I don't know when to pull that trigger, when not to.
I think it's just, I honestly, there's so many factors, especially pre-hospital. We don't have as many, I guess, clinical
Tools.
tools and diagnostic tools.
Yeah.
To be absolutely, this patient needs an intubation. So I honestly feel you take what you have and you follow your gut.
Yeah. So we chat about this quite a lot. And I think that the reason that I really wanted to talk about it is because my brain has a hard time figuring out who's been doing RSI. I think the way that it was ideally supposed to be done, where you like immediately, like you push ketamine,
Kung
you push
Fu Panda
paralytic.
style.
Yeah, like it is like slam. You give them back to back, and then you just like hope that your patient's appropriately sedated while they're
I
paralyzed.
don't know anybody that's doing that in the critical care realm.
Right. So the way that I was like taught to do RSI, and mind you, my first ever paramedic partner that when I was in medic school was sitting in this room. But the way that like Austin always RSI'd when I was still in EMT, and then when I was going through paramedic school, was like we kind of varied between etomidate and ketamine, because we got ketamine kind of like right on the precipice of going into medic school, and but it was always like you give your induction agent and you wait until your patient reaches an appropriate level of sedation, and then you give your paralytic, because my biggest fear is having someone awake and paralyzed. Like
yeah, that's my biggest fear as a person.
I 0% want to do that to somebody, and so that's kind of how it always was in my brain. But now we're learning about like DSI, which I don't think is a new concept, but it is a new name. It's that. So talk
Yeah.
about this in more depth, and am I just missing the mark here?
No, I think that if you have been RSIing people, it should have been in a DSI kind of way. I think, correct me if I'm wrong, DSI is like give a little, see what happens, give a little, see what happens. I don't know that is going to go over very well in the EMS setting because they cannot regulate it as much.
Yeah, it's like
So-
give smaller amounts of induction agent,
Right.
and then kind of like
See
wait
how that goes.
until you get there.
I think that's great for most scenarios, and it might even be good for, you know, some kind of service that has like a small group and everybody's critical care or something like that. But
Yeah.
I think when you have, which again, this ranges drastically across states, across regions, across the country, across the world, what your protocols are and what your service is capable of. I do think that it should be slow. I mean, you need to give your medication and wait for it to work and then give your paralytic. But I don't know that, because there are people and there are places where you don't have to be critical care to be RSI, that it's the, I don't know. I just don't know how you regulate it in a way that's like, I think that services would be nervous.
I think the biggest thing is it's going to come down to education, right?
Yeah.
So you get these new medics who are just out of critical care or paramedic school or however your service does it. The first few times that they're going through that RSI/DSI class or whatever, you have to set that expectation up front, right? So like if you want to change the culture, you have to start with the new medics coming into that, right?
For sure.
So obviously humans in general are very repetitive. They do what they know, right? So if you were to take somebody like me and throw something completely new at me, I'm not going to be as likely to do it as somebody like Aubrey who goes through critical care, and then, you know, so you have to roll it out systematically with a very robust education backing it, I think. And so I don't necessarily know. I think there's good qualities and bad qualities to both. And Jamie and I were talking about this earlier. The one thing that I struggle with is I have never, and I struggled with this when I went through critical care and everything. I struggle to understand what you are calling rapid and what you are calling delayed, right? Because nobody gives you a set
that's not a
time.
concrete.
Right.
Yeah.
And so some of my patients are going to be a little bit more rapid. But if I have the time, I would rather go slow and let's be methodical and make sure, right?
So like in my brain, if delayed sequence is 30 to 40 minutes, then I've never done that.
Right.
But if delayed sequence is like 10, I've done that.
Yeah. And see, I like delayed sequence as a moniker for the simple fact that it gets you to thinking about, we don't need to be so bam, bam, bam. You know what I mean? It slows you down. Let's use my brain. Let's take the time.
Right.
You know? I feel like if you give it a name like delayed sequence, or if you teach that name pretty systemically, you can really, going back to that cognitive offload and those kind of things, you can really slow your people down as far as, okay, this doesn't have to be so rapid.
Who named it
You know what I
RSI
mean?
anyway?
Right. I have
Random.
rarely found a patient that has benefited from truly rapid
Right.
sequence intubation, because
Exactly.
I think that when you have that, like, I like that you say, like, it's a good moniker, because I think that when you have RSI in your brain, you see red flags. Like, their patient is throwing red flags, like my blood pressure's dropping, or I'm
Yep.
getting really tacky, or my sats aren't coming up well, but you're like, I just have to do it.
Yeah.
And so now you're just like dropping tubes and doing things.
Yeah.
Because you've started this RSI process, instead of being like, okay, we're going to hang out for a little bit. We're going to see how we do with this induction agent. Oh, we're getting a little bit hypotensive. We're going to start a pressor. We're going to hang out here and see how that does. Now we're appropriately sedated. We have them pre-oxygenated. We haven't lost our airway reflexes. We've got a pressor on board just to kind of blunt that drop. And now we're going to give our paralytic.
Yeah.
I feel like that is just the most appropriate way to do it. Because if you're trying to beat your patient's crash with speed,
Right.
That is not how that works.
like, bro, you're going to
That's
lose.
just a head-on
Yeah.
collision.
Yeah, you're going to lose.
And that's why I've always struggled with that whole RSI, and now the DSI
Mhm.
situation. I'm like, well,
It
even
all is DSI technically.
right, even as much gray area as we live in our profession, I feel like a lot of times, especially, when you're giving things like algorithms and things like that, we like it to be black and white, right?
Mm-hmm.
It helps our decision making a lot of times, and so if you could label what delayed means for me, or you could label what RSI or rapid sequence is, then it would make my decisions a little bit easier.
Yes, I need, like, if you're going to do this in under 2 minutes, it's considered RSI.
Right.
If you're going to do it from 2 to 10 minutes, it's DSI. And
Right.
if you're going to do it in 34 hours, then it's the ICU.
Then please don't.
And that's what.
Please don't.
So rapid sequence induction was the original term, not
Oh.
rapid sequence intubation. So rapid sequence induction was originally used in the OR and was first described in the 1960s by Dr. Selleck, which is the same person if you've heard of Selleck's
maneuver, yeah.
Mhm.
But the point was not to rapidly not to push one drug and then the next. The point was to rapidly induce the patient so that they could secure the airway in patients that were in risk of aspirating.
So we essentially were just making the decision quickly
Yes.
to do it.
Yes,
Gotcha.
that is literally what they started as. And then it says it was basically adopted into EMS and emergency settings as rapid sequence intubation.
Gotcha.
So
Okay.
basically, this all boils down to, what is it that Kevin High always says? No ninja stuff.
Yeah.
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 That's what I'm saying. It's Kung Fu Panda.
Yeah, this is some
versus-
ninjas. Well, I guess what it has developed into, or the connotation of the title, is ninja stuff, when in reality, there should be no ninja stuff. You know?
No.
What is
Yeah.
the end goal of this patient? If we are already ventilating, you should have, ideally, all the time in the world to push that paralytic, right? You have time to manage hemodynamics and get this patient in a place to where you can secure an airway. And there are very few pathologies that push your hand in that, like burned airways and things like that.
For sure.
There's very few things that push your hand to not be able to do that.
Yeah, for sure.
So basically what this boils down to is terrible marketing.
That's what I was just going to say. I think really it almost sounds simple, and I'm really dumbing it down, but I think almost renaming it,
Go get them.
you know what I mean? Just taking RSI as a misnomer and naming it DSI
Right.
now.
That's kind of how
If
I
we
feel
can get
about
that
it.
accepted, then really
Yeah.
that kind of fixes the
I've just
problem.
been kind of looking around since this conversation, not like this particular conversation, but since like the more generalized conversation about DSI has started, and I'm just kind of been looking around being like, guys, isn't that like already
Yeah.
what we should have been doing? It's just
Right.
a new name.
Yes.
You
I think
guys
that's
are getting paid
100%.
for this?
Guys, I think that the point is the name just needs to be evolved, because I know we learned this one time, is that what is those things that like stoke the fire, blowing smoke up your ass?
Yeah.
They used to use those when you were drowning, okay? Just like you have like the little lifesaver in the box, okay? They used to
Yeah.
have the smoke, like the fire
The
stokers.
billows.
Like the billows.
Yes,
Yeah.
they literally shoved that up your ass, and that is how they thought
So they would ventilate
to
you.
ventilate you. Okay, so the point is, I think that we just need to pivot a little bit.
Yeah, this is just a rebranding.
Yeah.
Okay,
Yeah.
let's rebrand it.
If we're under
like
all
it.
the same assumption,
I
this
got
is a
one. You ready?
rebranding. Oh, I'm ready.
It's EESI.
What is
Eyes on the prize.
Effectively and expeditious sequence intubation.
Ooh.
I like it.
I like the word expeditious, so I'm in.
Expeditious.
I like it.
I like that.
Yeah, I think the only spot that I get like a little like about with DSI is that if we were specifically talking about giving little bits of induction agent
Yeah.
as we go along, like we're doing like 0.25 mg per kg of ketamine, and then we're just like dosing that kind of just to see where we get. I'm not quite sure how I feel about that.
To what you said, James, I don't know that that aspect of it has a place in pre-hospital emergency medicine.
Right.
Maybe not even emergency medicine, but we can hear that argument later. The purpose of that is to preserve hemodynamics and all of the things. And, you know, I just don't know that we have that kind of scene time. What are you doing? Doing that in the back of an ambulance that's moving? I don't think we have that.
Right.
I don't know how ideal or
Yeah, I think that
that would be.
when you're in a situation where if we're discussing delayed as we're giving doses of induction agent until we reach a sedation mark that we like, and we're delaying that to that degree because of our hemodynamics, I think that at that point we just pre-hospitally need to be focusing on hemodynamics.
Yeah.
And
I think so.
oxygenating to the best of our ability with bagging them and things like that. But I think that if we're that far down the tubes hemodynamic wise, that's kind of where our focus needs to be.
Yeah.
And I think that in that context, where delayed is this bumping of induction agent, I think that is where the argument lives, where people are like, I don't know that DSI has a place in emergency medicine.
Yeah.
I feel like the point was just to make an effort to express that we are not quickly doing anything.
Yeah.
And it's not really realistic to slowly, progressively do it
Yeah.
to that degree, I
Right.
think.
Yes, I think that in my brain, what I paint DSI as, and if this is just like literally not what it is, then okay. But what I have decided that it is in my brain is that we give our appropriate dose of induction agent, but we make sure our hemodynamics are in a good place. We give that. We let that live. We get that to a place where we have reached full sedation, where we see where our hemodynamics are. We pre-oxygenate effectively, and then we push our paralytic. I think that to me is what delayed is. Now, if we were just doing little bumps of ketamine for
That freaks me out.
for 20, 30 minutes, I don't even know.
Yeah.
Then
May as well just do an infusion.
then I just try to drip, I guess. I'm not really sure. But yeah, I just feel like it's not as clearly defined as I want it to be.
Yeah,
think-
it's not. But I definitely like going more the route of delayed sequence intubation, even though all we're really doing is changing the name. Like I said, I think
Yeah, but maybe it's time to change the name.
with newer
since-
providers, you'll get that cultural shift
Yeah.
of
Sure.
and hopefully maybe just slow them down a little bit to be like,
Oh yeah.
okay, let's sit back and because classic example is whenever. Not when I went through critical care, but when I went through paramedic school, there was no such thing as, the no DSAT. And I don't know how
Yeah.
far across the country that reaches, but no DSAT's basically where you put them on, high flow nasal cannula before you.
It's pretty standard now.
Right, it's pretty
but-
standard practice. Well, when I went through paramedic school, it wasn't.
Yeah.
And so when we discussed RSI
Yeah.
in paramedic school, there was none of that. You just hyperventilate them, right? And
Which is crazy.
right.
Yeah.
We don't do that anymore. So I think if you can catch this RSI DSI debate and start teaching that in places like paramedic school and your critical care programs
sure.
and those kind of things, and teach it basically the same way. You're just labeling it a little bit different. I think it kind of gives you that ease in your mind whenever you're like, okay, I'm going to DSI somebody.
Yeah.
I'm delayed. I've got time to oxygenate them. I've got time to
Yes.
make sure everything is where I need it to be so that we do lessen the chances of any kind of adverse,
Yeah.
issues.
I feel like on all of our brains, the way that a lot of the brains that land in EMS work is we create these lists in our head. And I think in DSI, it starts at the very beginning.
Yeah.
I am going to oxygenate you now.
Mm-hmm.
And I think in RSI, it starts at drugs.
Yeah.
And
I
that's
think
not
that's fair.
that's not necessarily
to say.
true. You should still be doing all of these forward
But
steps.
I think that was even the intention,
Yeah,
right? This
the-
was created in the 1960s.
Yeah.
I'm very certain that was probably the intention.
Yeah, the name of it is drugs go.
Yeah.
Yeah.
And so I think that it jumps your brain down the list so that you're almost having to like backtrack your brain
Yeah.
to get back to the beginning of it. One of our biggest like paramedic schools in our region is Columbia State Community College, and they are already teaching like a DSI approach. And so all of the medic students that we get coming from there, even ones that work at our service, I mean, they are like making this decision with confidence. They are walking through it very like almost metered, like they were using just
Yeah.
like a really
It's chill.
effective and slow and like chill approach. And that is just not something that even when I was in medic school, that was not, we were learning those concepts, but it was like, if you're going to make this decision, it's go time.
Yeah.
Go, 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 go.
Yep.
And I like that they're a little bit
Yeah.
more laid back.
It's wild what changing the
Right.
name or, you know, how it is
For
described.
sure.
And I think
How little that, you know, can have such a vast
For
change
sure.
on.
That's what I was going to say too. I mean, you can just start that at the education, like at the school level or the service level, where you change your protocol or procedure to reflect
For sure.
a more.
Like, the RSI that I did that went poorly, that it was like kind of a DAI, but kind of an RSI, and it was really just a cluster of a disaster.
For those who don't know, DAI is drug assisted,
Yes. Drug assisted
no
intubation.
paralytic.
And so like that was one of my first like choice. I made a choice to take an airway, and it went so poorly. But it's because my brain had RSI in it.
Mm-hmm.
It was like I have to do this. I have to do this right now. There's no time.
Yeah.
Had it had a different name, I think my brain would have read it differently. I would have been like, okay, like we're going to start here. We're going to start ventilating. We're choosing to take this airway, but we have all of these steps before we get there. I think I would have approached it
Yeah,
different.
definitely.
And so that's why I like the shift in name.
Yeah, I think that it's a whole new procedure then, like you said, Austin, versus when you went to school, then when Jamie went to school, then when I went to school, and then when Aubrey went to school.
Yeah.
Like it slowly evolved into something else.
Right.
Mhm.
Yeah.
Because
It went from RSI to DSI, kind of, you know,
Yeah, a
slowly.
little bit, yeah.
Slowly evolving.
Yeah.
Even though the name didn't necessarily change, the practices did.
Yeah,
For
for
sure.
sure.
Yeah.
That's a cool evolution. We needed to sit down one at some point and talk about how
Yeah.
school and our education
Yeah.
changed.
Yeah, because
Yeah.
we're
in
not that.
sequence.
Because it's like enough years for it to be different, but
Mhm.
not so much that it's like wild.
Right.
Yeah.
Yeah,
Subtle changes.
Yeah.
So what we're saying is psychology works.
it really does. The way that you frame something in your mind really changes how you approach intervention or like a whole call or whatever it is.
Yeah.
Yeah.
I'm going to give a shameless plug here for literally no reason other than I'm kind of obsessed with this book right now. I just finished it the other day. It's called Revenge of the Tipping Point. And I will not elaborate any further than that. Although if you like psychology, you would like this book. That
Very
is all.
nice. Thank you for that recommendation. Well, whatever you call it, RSI or DSI, just know it's not about speed. It's about being deliberate, coordinated, and calm in the middle of chaos. That's what makes you a clinician, not just a tube dropper.
Dum dum dum.
That's dumb.
Mic
but
drop.
Don't be a tube dropper.
Don't be a tube dropper.
Or a tube dropper.
That too.
Yeah, we don't do that
Be a
either.
resuscitationer.
Keep that on the up and
Yeah.
up.
Be the resuscitation.
Have you ever told everybody the time you put the sign in the truck?
The no bad attitude
Yeah.
sign?
Yeah.
Oh.
I think
could
we
do a
have
whole
talked about
episode
it.
on
Yeah.
EMS psychology.
Let's do it.
No bad attitudes.
They've been asking. We'll deliver.
Oh, yeah, we will do it.
All right.
See you next time.
This has been Life in Sirens, produced by three nerds trying to bring you content that you might actually care about.